My name is Nancy O'Hagan. I'm the president and founder of the Caring for Carcinoid Foundation. I'm a metastatic carcinoid patient, and I started this foundation shortly after I was diagnosed. The mission of the foundation is to discover a cure for carcinoid cancer. The vision of the foundation is to eliminate the suffering and to support neuroendocrine tumor patients, their families, and their friends. Today we're at the Nebraska Medical Center with 3 fantastic doctors who are really setting the standard for care for carcinoid and related neuroendocrine tumor patients. I'd like to turn it over to them so that each of them may introduce himself, and we'll begin a terrific program today.
I'm Botha. I'm a liver transplant and hepatobiliary surgeon at the Nebraska Medical Center. I've been here for almost 7 years now. Carcinoid is not been a speciality of mine. I wouldn't call myself a carcinoid expert. What I would call myself, however, is an expert liver surgeon, and I've been fortunate enough now to deal with a number of patients with neuroendocrine and carcinoid tumors, and have been very satisfied with the results that we've obtained in operating and treating these patients.
I'm Greg Fitzke. I'm a general surgeon from the Lincoln community. I'm a community surgeon without an academic background. I'm not a carcinoid expert or specialist per se, but we have, through this collaborative effort, worked on several patients with carcinoid, and that's what brings us here today.
I'm Mike Zaruba. I'm a family practitioner, primary care specialist. I'm from Auburn, Nebraska, which is a rural community in Nebraska, 3,500 people. I also don't consider myself necessarily a carcinoid expert, although have developed a great deal of knowledge on carcinoid simply because of the number of cases of carcinoid I've seen in our community. And through that research and the collaborative effort with these physicians, I've taken care of a number of carcinoid patients now, and find myself learning more and more about carcinoid every day. So.
Terrific. Well, today is very exciting because of the expertise that the 3 of you have accumulated through your recent patient pool. So I'd like to begin with a general question about how you would treat a patient, a carcinoid patient, and what you would recommend for the standard of treatment for a carcinoid-related neuroendocrine tumor patient. Dr. Zaruba?
Well, the treatment of carcinoid is, as we all know, is difficult. It's a cancer that in the past has been considered to be a slow-growing cancer, and one that sometimes doesn't get the attention it needs to. And I think that the treatment of carcinoid has to be, number 1, individualized, and number 2, it has to be a collaborative effort between not only the primary care physician, but the specialties you see represented here today, and sometimes other specialties. As we know, carcinoid has many presentations, many manifestations, and can affect almost any tissue in the body. And so I think it has to be an extremely collaborative effort. It has to be an effort of all the physicians working together and communicating, because that's the only way you're going to get the individualized care that these patients require. And so that in and of itself, I think, is the most important first step in the treatment of carcinoid.
Terrific. And so let's talk amongst ourselves a little bit more about this issue of collaboration, because I think it's such an important one, and it's a lesson that we've really learned here with the 3 of you, that I've learned a lot by speaking with you just so far. Can we speak a little bit more about that? What would you, Dr. Botha, what have you learned about collaboration with Dr. Fitzke and Dr. Zaruba?
What I've learned is my preconceived ideas about it have been smashed, and the ease with which it can be done. We're in a fairly rural part of the country, and me being a very busy hepatobiliary surgeon, it's my the job of calling referring doctors and speaking to them, and the usual thing of just sending a letter or making a single telephone call is what normally gets done, and not much more than that. What I found in this situation was I pick up the telephone and make a call, or I send a letter, and it's only to have it responded to within 24 hours or not more than a day. Things like x-rays being made available to me immediately. The latest collaboration we have is that I'm able to look at the CT scans that these guys order down in their clinic. I can see them as soon as they can see them. We can look at them together. We can be sitting on the telephone looking at the same scan and discussing options for treatment. That kind of collaboration is something which is new to me. It's always been collaborating with referring doctors, has always been something that you don't even know the face of the person you're talking to. In this situation, I mean, I know exactly the guys I'm talking to and dealing with, and it's been made easy for me, who's a busy surgeon. It's been made very easy for me to be able to. I know that when I call down there, I know that I'm going to speak to the guy that I want to speak to, and so they've done it more than I have in terms of being able to take care of these patients, make decisions, come up with plans. That the patient's not waiting another week to come and see me. They've left a message. I've said, oh, well, make an appointment to come see the patient. The patient doesn't end up waiting. They can have an instantaneous answer because of the way that we've been able to communicate with each other. So I've been extremely impressed with what's been made available to me and the responses that I've received. So I can't take a lot of credit for it. I think it's very much been driven from Auburn, and I give nothing but good things to say about it.
Fantastic, and this is a great example of 3 different cities. Each of you is in a different city. Dr. Fitzke, you're in Lincoln. Dr. Botha, you're here in Omaha. And Dr. Zaruba, you're based out of Auburn. Yet the 3 of you are collaborating together to treat patients with carcinoid and are having remarkable success in doing so, in large part due to the collaboration. Dr. Fitzke, what kind of lessons do you think other patients can take away from this? And what would you recommend to other doctors watching this to create a successful collaboration?
I'm actually hoping that more doctors take something away from this than patients, quite honestly, from the standpoint of the collaborative effort, because that's exactly what it takes. It takes an effort on the physician's part to communicate in a manner that Dr. Botha, Dr. Zaruba, and I have. It's very easy to look at a Post-it note on your desk saying a physician called and trying to push that off onto one of the individuals in your office to try to take care of it just so that you can move on to your next scheduled item. The standards of communication between physicians, I think, requires some improvement, and that's what I've been so impressed with in this particular situation with Dr. Zaruba and Dr. Botha and myself, is that I've actually learned to communicate with physicians in an improved manner. There is no busier physician on the face of the planet than somebody like Dr. Zaruba, who's in a rural setting taking care of everybody in the town. Dr. Botha and I are both busy surgeons, but we couldn't hold a candle to Dr. Zaruba's schedule. Dr. Zaruba talks to me on a weekly basis, sometimes on a daily basis, regarding individual patients, and any physician that can take that time out of their schedule to talk about individual patients with a referring physician, well, we all as physicians need to take a lesson from that and learn that we can take that time out of our schedules as well. So from the patient standpoint, you want to find a physician like Dr. Zaruba who's going to take that extra effort to communicate on your behalf in a way that gets things taken care of. First patient that Dr. Zaruba and I worked on, who is here with us today, it would have been real easy for him to simply have called my office, made the referral. We would have had her in the office probably within a week or 2 as opposed to 24, 48 hours, and her surgery potentially could have been scheduled 2 to 3 weeks out as opposed to a few days. But the extra effort he took to show that he had concern regarding the situation, he communicated to me what the problem was and that this could not wait a couple of weeks, and subsequently we were able to expedite things, and it takes that effort on physicians' parts to communicate with each other to make sure that patients get the care that they need.
Terrific. And so, Dr. Fitzke, do you think that, and Dr. Zaruba, do you think it's the use of email that has improved the communication among the 3 of you, or do you think it's the internet, or just initiative, or it's the telephone?
It's the initiative and the telephone. I'm not technologically that advanced with a computer. Dr. Zaruba recognizes that when he wants me, he calls me. I know how to use a phone, and it's easy to pick up the phone. So.
I think it's the personal relationships that have developed, over time. It's, I know who I want taking care of my patients. I know what their expertise is, their skills. And I think those personal relationships, I mean, it's you would think it should just be this easy that all physicians should be able to do this, and we should. And that's not the standard out there, but I think it can become the standard. But it's the personal relationships that develop, and being able to, when I call Dr. Fitzke, he knows exactly what I'm getting him into, what the issue is, and with regard to carcinoid, a couple different carcinoid patients he's operated on, he's not going into this necessarily just with a scan and some patient history. He's going into this hopefully with a pretty good understanding of what I've assessed the situation to be, and I got to hope that helps the patient in the OR. It certainly helps them post-operatively, and as we take care of these patients post-operatively, I knowing what they did, them knowing what I've done, just furthers the care, and it doesn't allow for details that can't be missed to be missed.
Terrific. Well, I think, why don't we turn to more specific questions? And I think that this terrific model of collaboration will continue to be seen with your dialogue about what we will discuss next. So, Dr. Botha, let's turn to you and discuss specifically what types of surgery you specialize in and how long you've been practicing, and the nitty-gritty of your practice.
Sure. So, I've been a hepatic or liver surgeon for probably close to 10 years now. My primary speciality is liver transplantation here at the medical center. We have a huge non-transplant hepatobiliary practice. So my time is split between transplantation and non-transplant liver surgery, which takes up most of what I do. In doing that, I'm ably supported and allowed some room to be able to do some fairly aggressive things. And I've been, that gets back to the Nebraska Medical Center supporting me in that effort, and the partners that I have, and have allowed us to do some things which are fairly radical, and notwithstanding our patients that have allowed us to do some of these things as well. But in terms of aggressive surgery, I like to think that we're at the forefront of doing what is the most cutting-edge hepatic surgery in terms of aggressiveness, moving the ability to resect forward, being able to take more and more pieces of liver out, allowing liver to regenerate. So there are a bunch of things that we're able to offer here, from simple things like laparoscopic liver resection to laparoscopic radiofrequency ablation, percutaneous radiofrequency ablation, in terms of the surgical therapies, open surgery to massive liver resections. We're comfortable in removing 75% of somebody's liver, knowing that the remainder is going to regenerate. The newer things that we've done more recently are staged liver resections, taking out portions of one side of the liver, allowing the remainder to regenerate, and then go and take out the remaining tumor in the liver. We use things like portal vein embolization to stimulate regeneration of a future liver remnant. And again, liver transplantation is always an option for us and our patients who have neuroendocrine or carcinoid tumors, as a means to further enhance long-term survival. So we feel like we're doing the latest and the greatest and trying to push the margins of what's doable, while getting back to how long we've been doing it. I mean, I've been here only 7 years, 5 years as an attending surgeon. I did my transplant training here for the first 2 years. So again, neuroendocrine tumors are rare, carcinoid is rare, so any one surgeon doesn't accumulate tons of those in a short period of time. So while we haven't got huge numbers and huge results to be able to publish at this point in time, I suspect that will happen over the next few years.
And so let's talk about the patients that you have seen. Let's talk about maybe how many neuroendocrine tumor patients you have seen, and what kind of damage to the organs that you've seen as a surgeon.
So I've mainly been referred patients who have metastatic liver disease from the neuroendocrine tumors. Offhand, I can already count 15 patients that I've seen over the last 5 years. 10 probably in the last year, as we've Ruth has allowed us to do something aggressive to her initially, and this has spawned a a number of patients been referred here and coming here. But just in the last year, I've seen probably I can recall straight off 10 patients with carcinoid tumors metastatic to the liver. All the patients I've seen are patients with metastatic tumors.
So first, let me just explain. Ruth Gertis is a patient of yours. She is the reason why we're all here today. She has been extremely generous in sharing her story with all of us patients and in creating kind of the instrument of your collaboration. And we're going to talk a little bit more about her surgery. She's very graciously agreed to allow us to talk about it because it sounds like a very aggressive and new procedure that you performed.
Absolutely. I'd read about this procedure. There's a French group, a leading French liver surgery group in Paris, that had published this technique in patients with metastatic colon cancer to the liver. A small number of patients, but it reported fairly good results in patients who were otherwise considered inoperable with large tumor bulk in their liver. They then hadn't published anything for a while, and Ruth came along and I had this sort of ideal scenario of where she had a large bulk of tumor in the liver, which would have normally been considered not resectable because of the bilobar involvement, both sides of the liver being involved. And discussing it with her, I thought, this is something I had not done yet, but was quite willing to do. And she was otherwise young, otherwise healthy, and I felt would have tolerated aggressive surgery. And she agreed to go through with this, and we've seen a very good result. And we've done it again, and we will continue to do it based on the good results. And in this year subsequent to this, we've been vindicated. That same French group has published earlier this year in an eminent surgical journal their results on 21 patients, I think it was, with metastatic neuroendocrine tumors that they've applied this technique to, with superb results. We're talking about 80% survival at 8 years.
Which is so exciting, and we'll make sure to have that article available on the Nebraska Medical Center website and also on the Caring for Carcinoid Foundation website, just so patients and doctors know that they can know where to find it.
Right.
So that's very exciting.
Phenomenal results, and again, hopefully we can duplicate these results over time with applying these strategies. And it's aggressive surgery, but the results are now, there's ample results showing that aggressive surgical resection, removal of 90 to 100% of the metastatic disease results in obviously relief of symptoms, but does improve long-term survival. And obviously Ruth did not have symptoms. Her carcinoid did not secrete, but this was with the goal of improving her long-term survival, and hopefully we will achieve that.
It's very exciting, and from what I have spoken with to Ruth, she's very excited about it as well. And so I think this is a great example of another example of collaboration, that the kind of collaboration we were speaking about earlier. So Drs. Fitzke and Zaruba, what did you think when you first heard about this procedure that Dr. Botha proposed doing? Did you, what came across your minds when you first thought about performing it, being involved with it?
Go ahead.
Well,
I'd be interested to hear this answer, because I don't think I've heard it yet.
Yeah, I don't think we've ever talked about this. I think from, I have to back up just a little bit. Ruth was, when she came to me, I knew we had a big problem. And I'll be very honest about where I was at. I wasn't really sure what we needed to do. But I knew, we could work on this. I knew we could research it and we could figure out some answers. And we came to Dr. Botha through, you talk about collaboration, we came to Dr. Botha through a third-year medical student. Dr. Fitzke had performed the primary resection and had suggested that we get Ruth to a liver surgeon. At the time, Ruth's nephew was here at the Nebraska Medical Center, and it was kind of a collaborative effort among all of us to get to Dr. Botha. And I can tell you, after all the research I had done, and I had done a lot of research and talked to a lot of experts, I knew immediately that this was the right way to go. I knew from doing the research and looking at things that surgery, not only does it improve mortality, it improves our quality of life. And so, from my standpoint, I was extremely comfortable with it, and I feel like a weight was kind of lifted from my shoulders by Dr. Botha, and so that's what I think.
Terrific. Dr. Fitzke?
Well, I was excited. Of course, all of us that go into surgery are excited about being able to separate the patient from their disease. And carcinoid is a very rare tumor, as everybody has alluded to at this point in time, and there are no fantastic, miraculous medicines that you can give carcinoid patients to absolutely obliterate the tumor. So anytime you can separate that tumor from the patient from a surgical standpoint, it's obviously very fulfilling. Now, because there's so little known about carcinoid, some of us do become a little pessimistic about advancing the amount of surgery that you do for somebody with this particular type of disease. But based upon his research and his expertise, we were very excited that we had somebody with his expertise in the area that could potentially even approach a novel procedure such as this. And so it's very exciting to be in an area where you have those resources available to you.
That's wonderful. And so turning back to you, Dr. Botha, so it sounds like, do you want to describe a little bit more about the details of the procedure? It sounds like it's a two-step process, is that correct?
That's correct. So you have a patient with metastatic disease in the liver, which is obviously not resectable by conventional means, which would be either a left lobectomy or a right lobectomy or an extended resection on one of those two sides. There's tumor obviously throughout both lobes of the liver, and clearly by taking one half you're going to be leaving tumor behind and probably not impacting long-term survival if tumor is left behind. So the goal of this is to remove 90 to 100% of macroscopic tumor, and at the outset you plan on going in and taking either from the left or the right lobe. So let's separate the liver into two halves, a left and a right. You attack the one lobe first and remove all disease from that lobe of the liver. And really what it is making that lobe into Swiss cheese. It's just taking out tumors wherever you see them and clearing out what is going to be your future liver remnant. So you make sure that you get all the disease you can out of that lobe of the liver. The remaining lobe is still packed full of tumor. We then, either in the operating room, ligate the portal vein to that section that still has tumor in it. And what that will do is stimulate hypertrophy of the remaining side that you've just cleared out of tumor. Or I can have one of my radiologists do what we call portal vein embolization, and it's percutaneously stick a needle into the liver and actually block off the blood supply for me to that side. And that stimulates our future liver remnant to grow. Once we've allowed it to grow within a period of 6 weeks to 3 months, we then rescan and make sure that it has grown and that there's still no residual tumor within that lobe of the liver. We then go back for our second stage and remove the remaining portion of the liver that has still got tumor in it. So with that two-stage procedure, you've removed all the macroscopic disease from the liver and you've left a liver remnant with no tumor in it. And that's allowing the capability of the liver to regenerate to work for you. The beauty of carcinoid is because it's slow growing, you've got the time to do that without the risk of metastasis occurring. That's why it's difficult to apply to other tumors such as colon cancer, liver cancer, is that 6 week to 3 month period that you need for the liver to regenerate, you're at risk of tumors metastasizing, tumors growing and becoming uncontrollable. So neuroendocrine tumors that's why this is a particularly good procedure that's suited to these tumors, because they're slow growing, and it gives you the time to be able to do that.
Interesting. And so before we move to the next step, what neuroendocrine tumor patients would you recommend this procedure for, this liver procedure for?
Well, any, in fact. It's not restricted to carcinoids. Pancreatic neuroendocrine tumors that are metastatic to the liver, again, the same thing can be applied to any of them because the majority of them are slow growing. Those that secrete, those that don't secrete. Again, you're going to change the symptoms, you're going to improve their quality of life, and you are going to improve their long-term survival by being able to not only debulk, but with the goal of actually resecting all macroscopic disease. So it's patients who have the primary is controlled or has been resected, there's no residual tumor at the primary, and there's no metastatic disease elsewhere other than the liver. There's purely just liver disease within the liver. Those are the patients we can be aggressive with, no matter what the endocrine tumor is, whether it's a gastrinoma, whether it's a pheochromocytoma, whether it's something from the something else from the pancreas that is metastasized, or any other gut neuroendocrine tumor. So
I see. And then for the liver presentation, what do you look for to determine whether this patient should undergo this procedure?
Right. It's the goal is visualizing a future liver remnant that's going to be free of tumor. So you've got to be able to, at that first operation, be able to remove a tumor from a lobe that you're going to preserve. And you've got to be able to show yourself that you can get all of that out and have a lobe of liver that is free of tumor.
I see. And what would you see that would make it difficult for the lobe of liver to be free of tumor?
Again, it's just multiple tumors in difficult places to get at.
Okay.
Again, near to vital structures, at the portal bifurcation, the hepatic artery bifurcation, where the hepatic veins are going in. Those are what's going to make them difficult to get out. If they're wedged into blood vessels that you have to, between blood vessels that you have to keep, between bile ducts that you have to keep and preserve to allow the future remnant to function normally. So that's what's going to make it difficult and rule patients out of the procedure if we're unable to clear that future liver remnant.
And can you see all of that on a scan before you go in?
Correct. That's how we make that determination.
Okay.
Obviously, patients get the routine imaging studies that most neuroendocrine tumor patients get in terms of octreotide scans, CT scans, MRI. We've become very impressed with the MRI scans for neuroendocrine tumors. They're particularly good at detecting them, particularly good at showing us where they are, what their relationship to vital structures are, more so than CT scans in our experience. We have a superb dedicated abdominal MR radiologist here at this hospital that is a specialist in liver MRI imaging. So I've become very impressed with MRI as a technique to be able to aid me in having a roadmap when I'm in the operating room, knowing what I'm going to be looking at. Obviously, in the operating room, we do use intraoperative ultrasound as a further technique to be able to localize where the tumors are and try and enable us to remove them. We could, turn back in the operating room and say, no, we found something in there that prohibits us from doing this. But again, that hasn't happened yet, but it may in the future.
Okay, and so then you were in the middle of describing the two-step process.
Right, so once you've allowed that liver remnant to grow, the second stage is going in and removing the bulk of tumor in the remaining lobe, just taking off the entire lobe with all the tumor in it. So again, it is 2 operations. It's a big deal. They're 2 major surgeries. 2 liver resections is a lot to ask anyone within about a 3 or 4 6 month period of time. But so far, again, I've been impressed with the patient's ability to tolerate it. Most of them have done very well. Fortunately, I've had no one with carcinoid heart disease yet. That would complicate liver resection. But again, it's stuff we know what we're looking for in patients with this disease. We look for it beforehand, and hopefully we're as prepared as anyone could be in operating on them.
And what kind of complications, just to detail them specifically, would patients have to be aware of before undergoing these procedures?
Okay, well, carcinoid patients in particular are always at risk of a carcinoid crisis in the operating room, and that's something we obviously try our best to avoid and are well prepared for that. And that's unique to patients with carcinoid. Carcinoid heart disease as well results in unique complications and makes bleeding a big problem in liver resections. Again, we try to be well prepared beforehand. But then unique to liver resection itself is you're cutting across an organ that's extremely vascular. Bleeding is always a problem in the operating room. These days our techniques and our abilities to control that are very good, so it's become less of a worry. In the post-operative period, again, because you're cutting across a piece of liver, you're cutting across bile ducts. Bile leak from that cut surface is a 1 out of 10 chance that you're going to get that problem, but it's usually benign, easily controlled, and easy to fix without having to go back in the operating room. Then any complication attendant to any other major abdominal surgery, wound infections, pneumonias, urinary tract infections, blood clots developing in the calf veins, those are things we're acutely aware of and make every effort to prevent. So in terms of the uniqueness, it's just a big operation. The risks in terms of bleeding are there, but we, again, take every effort to, we know how to deal with this now, the techniques and technology that's available to us.
And so how did the 3 of you work together after this procedure to deal with any complications that arose?
Well, I'll just start quickly and say
Okay.
that, I mean, patients are in hospital for a period of time, and I'm able to discharge them to the care of Mike, who I know is going to take care of most of what, most everything that I, ask him to do. And again, the ability to email me, call me, send me radiological images, it's so easy to communicate and have the patients taken care of in a setting which is away from the hospital, at home with family, which is obviously better for them and extremely easy for me.
Terrific.
I don't know if I have a whole lot to add to that. I think it's just, they get back into, their hometown. They're able to be in their own home. They're able to do the things they want to do. And I think that in and of itself just accelerates recovery, and you start to feel more like a normal person again. I think, we have such a line of communication that if I have a problem, I know who I can pick up the phone and get a hold of and discuss that problem with. We do share information. Technology-wise allows us to do that. We share information electronically, like the scans and everything. Our lab in our office is set up to, when that report comes out to my desk, it's already been faxed to Dr. Botha or to Dr. Fitzke if it's a preoperative type of situation. We do use technology and to help keep everybody on the same page. And so I think when a patient can get back to their primary care physician who can kind of be watching everything, and we go into this assuming we're just talking about carcinoid, but we may have hypertension, we may have depression, other things that we deal more with, and so we know what those issues are, and we can take care of them and work collaboratively together on the problems, the post-operative complications, whether that's a pleural effusion or whether that's a wound infection. We can talk back and forth, and if we save them a trip, coming back up to the tertiary care center, then that's just even better for their care. But if we need them to come up, we make those decisions, and so it works well.
Terrific. And Dr. Fitzke, let's talk about your role in Ruth's surgery and your role in this kind of surgery generally.
As a general surgeon, we're faced with obviously situations like Ruth, not infrequently, and most of them don't turn out to be carcinoids. Part of it is you just have to have a high index of suspicion. When somebody as thorough as Dr. Zaruba calls you and says, this is what's going on, you need to open your ears, you need to listen, you need to realize what you need to do and when you need to do it. And that was kind of what we did with Ruth. We got Ruth up, we talked about what this could be. Quite honestly, I was not expecting it to be a carcinoid. I thought this might be a lymphoma or something along those lines. We approached it with the idea that we would, and as any general surgeon should, you approach something that you realize you can handle, and you leave the things that you can't handle to those with skills to do so. And that's what we did with Ruth. We simply we resected the area of small intestine mesentery that was involved with a gross tumor. We biopsied the spots that we could see in the liver, knowing that I didn't have the expertise or the ability to resect those areas. But we could confirm exactly what they were so that somebody with Dr. Botha's expertise could take it the next step and realize exactly what it is that he needed to do. So.
And what did you think when you received Dr. Zaruba's call?
It was simply one of those situations where Dr. Zaruba was entrusting me with the care of one of his patients, and I simply hoped that I could provide whatever care that was necessary for Ruth. So.
And I want to jump in here because I think this is a very important point that needs to be made for carcinoid patients. Dr. Fitzke is the whole key to making this work. Had he gone in and done things that, as he said, maybe was outside of his skill set, or had attempted to, I'm going to do everything I can for this patient, but maybe it wasn't, it could have severely inhibited Dr. Botha's ability to do anything. And I think that communication that he had beforehand, his skills as a surgeon, is what allowed us to get to the next step, which is to be a candidate for what Dr. Botha can do. And I think that's a lesson, unfortunately, in another carcinoid patient that I'm taking care of now, the surgeon didn't do that, and did some things that maybe we wished wouldn't have been done. And I think that's very important for a carcinoid patient when you go to your general surgeon, for your primary care physician to communicate with them, to have good general surgeons that can understand the process of what needs to be done and what doesn't need to be done. Sometimes that's more important, and that's just the key to Ruth getting to the next step. And so even though Dr. Fitzke will downplay it, I think that was an extremely
his role
important
was
decision.
critical.
That decision was made in the OR, while he's, doing the surgery that gave rise to the ability of Dr. Botha to come in and do the resection.
And Dr. Fitzke, what made you decide to go that route of the biopsy and not attack it further?
The areas on the liver and on a CAT scan, although were plentiful, they were relatively small. We knew we wanted tissue from those areas to prove exactly what it was. Again, sort of anticipating that it was something less rare and potentially something more commonly seen, such as a lymphoma. My radiologic colleagues thought that they were too small to be able to reach adequately, and we knew that we had to go in and resect the area of disease near the intestine because that was obviously potentially a hindrance to her gastrointestinal function. So we simply opted to start laparoscopically, be able to visualize the liver better, and simply being able to identify one particular location where the lesions were present, biopsy it so that we'd have that information, and then go ahead and tackle the bulk of the main tumor. That's a discussion that I had with Dr. Zaruba and Ruth, and that worked out very well for us.
Terrific. And how many procedures have you done on carcinoid and related neuroendocrine tumor patients?
Well, thanks to Dr. Zaruba. More than I had prior to our interaction. Shortly after Ruth came another patient from the exact same vicinity with a very similar type presentation, only at least on CAT scan, did not have any evidence of liver disease, and as it turns out, that's what we found out at the time of operation as well. You simply have to approach these with oncologic principles of being able to remove all tumor that you possibly can in hopes of gaining clear margins without hindering the potential for other therapies to potentially work as well. And basically, what I've really learned is having a high index of suspicion. Again, carcinoid was certainly on the list as we went into Ruth's case, but it was quite a ways down the list simply because we just don't see them that very frequently. And so having a high index of suspicion, taking a case like Ruth's and personally learning from it, and then the collaboration that the three of us had, knowing exactly what we could do for each patient afterwards, has been very important to my education as well as my practice. So.
Terrific. And I'd like to touch on that issue that you brought up of the additional carcinoid patients that you've seen as a result of Dr. Zaruba. Dr. Zaruba, it sounds like in your area there have been many carcinoid cancer patients diagnosed, more than you would expect for that area. Can you describe to us a little bit more about when you first saw your first carcinoid cancer patient? Was Ruth your first, and then how?
Actually, Ruth was not my first patient. I had seen a couple carcinoid patients in residency, although had not made the diagnosis myself. They had been, they'd come to me after being diagnosed. So I had a little bit of knowledge, but not, and I still don't consider myself an expert. But I've seen, since then, I've personally made the diagnosis in at least 3 cases, and we have approximately 6 cases in this small community where we live, and certainly that's concerning. That's a little bit unusual, and there may be some link there may not. But what I've learned though is if you don't think about carcinoid, you'll never make the diagnosis, and that's where the high index of suspicion comes in. And the diagnosis with Ruth was extremely difficult because of some things that had transpired prior to her actually coming in for the workup. But we thought about it. It was in the differential. We made the diagnosis, and I think physicians just have to have a high index of suspicion. They have to think about carcinoid, or they'll never make that diagnosis. And I think you have to convey that to your surgeons. You have to have a surgeon that'll listen. I mean, I could have called up a surgeon who'd tell me I was crazy. You never see carcinoid. What are you talking about? It's that rare. Dr. Fitzke listened to me. And we both honestly thought it was going to be lymphoma. I thought that, but it was on our differential, and we did the things that we needed to do, getting her ready for surgery. He did the right surgery. Everything then set up for Dr. Botha to come in and do the 2-stage resection, and now we have a patient with no evidence of disease, and we continue to follow her, continue to do surveillance, and that's probably the most difficult part, because you can't go to a book and really look up what you need to do, because there's not a lot of these patients out there. But we keep a close eye on all of them that are going through this, and again, something comes up, we talk and share information.
And from what you said, I think there are 2 important points. First, what made you decide to look at Ruth's CT scan again for the second time? Was it her CT scan or her MRI?
Her CT scan.
That you looked at for the second time?
Well, you have a way you work things up, and I had done just about every test I knew to do on Ruth, and at the end of the workup, it just wasn't making sense.
What wasn't making sense?
Well, initially what was proposed by the radiologist is that she had hemangiomas, which are benign tumors of the liver and require absolutely no intervention. But nobody could ever, solidify that. Well, it looks like a hemangioma, but it's got findings that aren't quite consistent with that. And there's multiple ones, and it wasn't adding up with what I know, I need to have for me to go to the patient and say, we're not going to worry about this, or we're just going to watch it, or it just didn't add up. And I don't know if I can really put that in words, but from training and from what I'd seen experience-wise, it just didn't make sense to me. And so basically I went back to the radiologist and I said, I think this is something more than a hemangioma. I think we're missing something, and I said, I just want you to look at the scan again. I said, you might tell me there's nothing more there, and it's that sickening phone call and that, devastating phone call. And he goes, Mike, we missed something. She has a huge mass in her small bowel. Well, then it started making sense, and I think as a physician, if it doesn't completely add up, you gotta ask yourself, are you really making the right diagnosis? And it didn't add up. 2 + 2 didn't equal 4. It wasn't coming up something short of that. And so I went back, and fortunately the radiologists are good people to work with, and they listened to me. Again, there's a collaborative example. They listened to what I was saying. I'm a primary care physician calling up and saying, I think we're missing something, and I'm trying to tell the expert, that they're missing something. That doesn't always go over real well, but we had a good relationship, and we found it. And and that's fortunate for Ruth and fortunate for all of us, and we need to, as physicians, have open minds and always listen. So.
And Dr. Zaruba, have you spent a lot of time since Ruth reading about carcinoid cancer and doing a lot of research? I hear laughs from everyone.
Yeah, more than I ever thought. I've learned more about carcinoid than I ever thought I'd ever learn about carcinoid, and it's fascinating to me. I think it's it's kind of neat. We can take the thing that makes carcinoid the hardest to treat, and that's its slow growth, and exploit it by doing something like what Dr. Botha does. We're taking the weakness and we're turning it into a strength. We're exploiting what makes carcinoid so hard to treat. And I think what's so neat for me is that we are bringing new options to carcinoid patients that I haven't seen out there. There's certainly other facilities doing surgery, but in Ruth's case, I can tell you I've talked to numerous experts, none of which would even consider a surgical procedure on her. So we're bringing new stuff to the table, and I think we're going to give options to patients who in the past haven't had options, and that's important.
Oh, I think that's incredibly important, and that's so exciting. It's very exciting to be here with the 3 of you today. And it sounds like what we can take from this example today and is first that patients should always push their doctor, it sounds like, or work closely with their doctor, and that communication is very important and collaboration among doctors. What other things would you 3 recommend that neuroendocrine tumor patients ask their doctors, or what should they look for? I think another thing that's so important here is that it's a multidisciplinary center at the Nebraska Medical Center. So you have terrific experts that can interface with primary care physicians. What else would the 3 of you recommend that a carcinoid-related neuroendocrine tumor patient should look for? Anything, or have we?
Yeah, you've pretty much covered it
I
all
think we
from our
have.
point of view.
Yeah.
I mean, it is important that you do push your doctor. Information is available to patients through the internet, through websites such as your own, and armed with that information, you are able to push your primary care physician and to be able to get to a place that can offer a multidisciplinary tertiary approach to this and incorporate the basic level of care that's needed for every patient. And patients have the power to do that, and they need to. They cannot accept an answer that doesn't feel right to them. And they need to seek out places that they have confidence in and doctors that they have confidence in, because, and this is something I've said before to our patients, is this. I understand that this is, when I see these patients for the first time, this is the single most important point in their lives. And I must recognize that, and us as physicians need to recognize that this is probably a big turning point in this patient's life, and this day is the single most important day in their life, is this meeting with you, with their physician. And you need to make it that you feel that as well as the physician, that this is a big day for them, and take the care that they expect from you. And that's a lesson we all, I think, have learnt and will continue to use in our practices, is that this is what patients expect from us, and we need to live up to it.
Terrific. I think that's a wonderful point on which to close. Thank you so much to each of you for your time today. And thank you to Nebraska Medical Center. It's a cutting-edge facility where each of these doctors are practicing and working together. I think it's very important that all of us patients listen to what they said and apply that to our own cases. So Dr. Botha, Dr. Fitzke, and Dr. Zaruba, thank you so much. Again, we're here at the Nebraska Medical Center. Thank you very much to the Nebraska Medical Center for allowing us to be here today. My name is Nancy O'Hagan, and I'm with the Caring for Carcinoid Foundation. You can find this interview at the Caring for Carcinoid Foundation website or on the Nebraska Medical Center website. Thank you very much.